you have been studying and researching chronic pain for decades now.
Yep.
Okay. You're a professor. You are well respected all over the world for your expertise in musculoskeletal pain. So at the start of this conversation, I'm really interested if there was one thing that you could impart to the public about pain, what would it be?
Hope. Hope for change. Hope that pain is something that has an ability to be controlled. Hope that if pain limits your ability to function, your ability to do the things in life that you value, that you can't do, that there's hope to get it back. I think generally there's a lack of hope around pain and chronic pain, pain that persists, pain that just is distressing and disabling. There's this sense that you just have to suck it up and live with it.
How many people these days are suffering with chronic pain?
Oh, it's the leading cause of disability of any health condition in the world. Chronic back pain is number one. It has a devastating effect on people. It affects their ability to work, their ability to engage in physical activity, normal activities of daily living. It has a pervasive effect. So we know from population studies up to about 20%, 1 in 5 people suffer from this, and that's for persistent back pain. It emerges early. So we often think of it as an adult problem, but actually it begins often in adolescence and then kind of tracks through life.
Yeah. I read a statistic this morning which said that 70% of people in developed countries will get lower back pain at some point in their lives.
Yeah. It's like the flu. It's something you will get, probably even higher in some cases, but it's incredibly common. The thing is, most back pain, well, the majority of cases will get better, and I think that's important to note, but there's a group of people where it becomes persistent or recurrent, and that's the group that really carries the burden.
Yeah. You said it's the leading cause of disability worldwide. This is chronic lower back pain.
Yeah.
Okay. I think many people will be surprised to hear that.
Yeah.
Now, firstly, if you've never suffered from back pain before, right, let's say you're in that 30% that apparently never gets it, okay, you may not realize the impact of actually having chronic back pain. You might think, well, what's the big deal? You know, what number one cause of disability? Are you kidding me? Like, what, a bit of back pain? So perhaps elaborate in terms of why it is so debilitating for many people.
It's interesting. We've part of our group have asked patients with back pain, like, why is this so debilitating for you? And they go, it's not like an ankle. You've got another one. You know, you can offload that ankle if or you can modify it. But with the back, it's the center. It's kind of like the center for so many things. It impacts your ability to sit, stand, bend, lift, engage in normal activities. So it's not like a limb where you can choose another limb, you only have one back. And so it's this fundamental part of the body that is linked to almost every normal activity of human function. And so when it becomes painful and debilitating, it just disrupts everything.
Yeah. For me, I had about 10 years or so in my 20s into my 30s of chronic lower back pain, which had a significant impact on the quality of my life.
Yep.
Yes, it was pain, but it wasn't actually the pain. It was more what it did to my confidence in myself.
Yep.
Like I had to second guess everything.
Yep.
Can I do this drive?
Yep.
Can I help my friend pick up his sofa that he wants me to help him with? Can I take the shopping up the stairs to the car? Right?
Yep.
Even I remember this very well. When my son was born, this is back in 2010, I remember days after he was born, we were back home, the doorbell went and I twisted and suddenly my back went. I couldn't go and answer the door.
Yep.
I had to call it to my wife, who I think was feeding my baby boy at the time. She needed help and support. And not only did she have to come down and open the door, but I think for 4 weeks, I wasn't able to help her and lift my baby boy. So what it does to your self-esteem and how you feel about yourself, I think is profound. This must be a story you've heard over and over
100%.
again, right?
Yep, 100%. So we know from a lot of qualitative research that back pain has such a disruptive impact on just the things you talk about, just normal stuff like just getting out of a chair, picking up your child, the ability to sit, to travel, to do normal stuff. And it kind of starts dominating you. You start becoming hypervigilant. You start thinking about what your next option is. The other thing that pain does to the body, and it's a whole person experience, because when you have pain, your body goes into protective mode. And when we go into protective mode around the back, we tense up. So we start protecting, guarding those muscles subconsciously start contracting and tensing up, which creates secondary processes of pain. Mm-hmm. And so you just see this cycle where you become hypervigilant. It's frightening. We know fear ramps up the nervous system. Mm. We overguard and protect. We start avoiding normal activities and movements. And then you start losing your life. And that's deeply, disruptive. Affects your mood.
You mentioned a couple of terms there, which I think people may not be familiar with. You said population research, and you've also just mentioned qualitative research.
Yes.
Would you mind explaining what those terms mean?
Yeah. So population research is literally looking at a large group of people. And so we've been involved in a study called the RAIN study, which was based in Western Australia, and it looked at people pre-birth, mothers who were pregnant, and it's tracked the population of babies then into adulthood. We were really lucky in that sense to kind of look at the development of pain in that population, to look at the factors that might be relative to that group of people. It's like about 2,000 young people, babies into adults. So that's at a population level to go, if we look at a population, what are the factors that are predictive of pain in that group? Qualitative research asks you as an individual, tell me about your experience of back pain. And you've given us that already. You've talked about the details of your experience, how it's impacted on your life, your ability to lift your child, that sense of I can't do something I value, that loss of confidence in the body. That's about qualitative research. It's the individual story.
Yeah.
Both are really important.
Yeah. If we think about back pain and we think about, I guess, the wider term chronic pain, are there similarities between the two?
Yeah, and they massively coexist. So we look at chronic back pain, which is pain that lasts more than 3 months. It's strongly related to neck pain, to headaches, to migraine, to gut pain, to pelvic pain, to widespread body pain. So there's a whole pain story, and often the back is one of the key elements and is often one of the most disabling aspects of pain just because of all the things we described.
Yeah.
So it's a pain story which is linked to sensitization within the system, within the nervous system, which affects all parts of the body, but the back seems to be particularly vulnerable.
You have previously shared in interviews your own story that you were a sufferer. And I'd love you to tell us a little bit about your own journey as a patient rather than a clinician and an expert. I'm sure, I would imagine that your own personal experience has hugely informed your professional expertise. But there was one bit in your story which really struck out to me, which was, I think, was it a friend of yours who saw you moving and was like, what are you doing, Peter? Like, you look rigid. You're not moving normally. You're kind of moving like a robot. Can you just elaborate?
Yeah. So that was pretty early in my career. So I'd trained as a young physio in New Zealand. And part of that training was like, focusing on body posture and mechanics and all that kind of stuff. I'd had an injury skiing, actually, where I'd landed very heavily on my back off a track. I'd misjudged it and landed smack on my back and developed pain and severe back pain. Luckily, I hadn't fractured anything. And then I tried to get back doing my life again, and it just became this pain started dominating everything. Just going to work became really, like, at the end of the day, I was exhausted and the pain was spreading. It was spreading up my back into my neck and around into my core, and I was starting to worry. I'm like, I don't know if I can do this job anymore. Where I'm using my body and I'm part of my job. And that was scary, actually. And then thinking, what can I do about this? And there was probably about 3 months in, a friend of mine said exactly what you highlighted. Peter, why are you holding yourself so tense or rigid? And I kind of looked in the mirror and I realized that I'd been overprotecting myself, of trying to hold my posture. All these latent beliefs that we have about backs of good alignment and strong core and all of these things subconsciously I'd been adopting and holding myself so tense, and it was exhausting. And I had this kind of moment of realization that actually this was not helping me. It was hurting me, and started to then relax and realize I was breath holding and guarding my back. As I started to relax and breathe and start feeling the confidence to get movement back into my back, that was my key to the change. And we've seen this in our research as well. It's like we know that we have this embodied experience with pain, that when we have pain, we guard and protect our backs. We move slower, we move stiffer, we're more clenched. And that in itself is a mechanism of overprotection, which is not healthy for the back. And I did it. I experienced that.
If that's what the body wants to do, though, can we argue that that's okay in the short term if you have an injury?
It depends.
Okay.
So if you have a spinal fracture, absolutely. It's very normal. Like, that's the body saying, protect your back. Don't move that. If you have a big disc prolapse, for example, which is, say a bulge from the disc that's compressing a nerve, your body will go into protective mode. It's completely normal. You want that. So that's the body saying, don't move. Give it a chance to settle down. Let the tissue heal. Okay. But a lot of back pain, acute back pain, I think this is where there's a misunderstanding. You can have back pain from an injury, like I did, and in the short term, it's normal to guard your back. But lots of back pain is not linked to an injury.
Most of back pain
is not linked to an injury.
Not just a lot. It's most of it, isn't it?
It is. And so if you look at a population level, back pain often emerges at a time when we're under stress, where we're tired, we're run down, we're tense, we maybe haven't been as active, when we're, got other stresses in our lives, and then it emerges. That's the back pain you don't want to protect, because there's no injury in that case. Do you understand that?
Yeah.
But we don't think that. These are normal subconscious processes that emerge in our body, that even in the absence of injury, with pain, we will protect.
I think
Does that make sense?
Yeah, total sense. And I mean, I very much resonate with your story, because when I was in the midst of my struggles with my back, and it's so lovely to be able to talk about it in the past tense, because it literally is in the past.
Yep.
And I've shared on previous podcasts, some of that journey. I'm sure some of it will come up in our conversation. But I remember those days where you'd learn how to lift properly, and you'd try and sit with your core on. Yep. And if you watch me trying to tie shoelaces or pick one of the kids' toys up, it's absolutely ridiculous on one level. If someone had a video camera on you, you don't look like a natural, connected human. You look like a robot.
Yep.
Right?
Yep.
And I understand why people are taught to do certain things, right? They're taught to lift in a certain way. But if you really think about it, people who lift with no pain, they're not thinking about their core.
100%.
They're not keeping their back straight.
100%.
They're just lifting and their body knows what to do.
100%.
So it's kind of nuts, isn't it, that we have an injury. I shouldn't even use the word injury.
Yeah.
We have an episode of back
pain event. Yeah.
A pain event.
Yeah.
And then we get taught to do a series of movements and actions. And I understand why we're taught that, because people are trying to help.
Yep.
But actually, for many of us, it starts to become problematic.
Massively. And it's misguided as well. Like if you look at the evolution of, ergonomics, for example, where we've taught people to lift with a straight back and bend their knees, there is no evidence that is protective of the back or that it will prevent an injury or pain event. It's just something that emerged many years ago from some very basic anatomical studies and some studies that looked at pressures and discs. And then we extrapolated this into the workplace.
Okay, so if someone's listening right now, Peter, and they're like, okay, you're saying there's no evidence for this as a recommendation.
Yep.
But I had backache, and when I keep my back straight when I'm going up and down and lifting, I don't get flare-ups. What would you say to them?
Great, go for it. but I suppose the point there is, like, if we look at the evidence, to say that if you don't do that, it's dangerous, there is none.
Yeah.
That's the point. And so I'm not saying you shouldn't lift with a straight back and bend your knees, but what you described is what we see in our research, is that people with back pain start lifting like that. People without back pain don't. And so one of our researchers...
It's nuts.
It is nuts.
It's utterly nuts, because it is the most unnatural thing in the world when you watch people.
It is.
You can tell someone's got a history of backache.
You can.
And I'm so passionate about this topic, Peter. Because I have suffered and had, the quality of my life decimated for at least 10 years because of chronic backache. I've come out the other side by adopting a very holistic approach, by dealing with emotions, psychological issues, yes, mechanics as well. Because it ain't just one thing in my experience. You've got to tackle 100%. It from all angles, like many chronic diseases, frankly. But also, I share the belief that I think you have, which is we as a profession, not just doctors, but also other healthcare professionals, without realizing it, I think we make the problem worse.
100%. 100%. Like if I look at my caseload of people who I get to see, the majority of what I see, I believe, would be healthcare-induced disability.
Okay, and who are these patients you're seeing?
These are people with persistent disabling back pain.
Right, so you're seeing you're still a clinician, you're seeing these people.
Yep, 3 times a week I work in the clinic.
Okay.
And the majority of people I see have beliefs that are not evidence-based, that have been given to them. They've got scans often. They've been told that their backs are worn out, they've got degeneration or disc bulges, that they need to protect their back and lift in a certain way and protect their backs and be careful if it hurts. And it creates a massive problem. And distress, the distress that goes with that's massive.
Yeah. Fundamentally, you were going through there what we are unwittingly doing with our patients a lot of the time. All of those things you said are, I was going to say subliminally, but not even subliminally, like quite literally giving the patient the message, there is something wrong with your back.
You're damaged.
You are damaged.
Yep.
You must be careful.
Yeah, 100%.
And it takes years to get rid of that.
And for some people, we know, we've done studies looking at these people, it can last a lifetime. We've looked at people who had 30 years of back pain, who have been told at a young age that they had a disc of a 60-year-old when they were younger, and it's set a trajectory. So we know that the things we say and the advice we give can have very long-term impacts on people. And we have to be so careful as clinicians that we don't frighten people unnecessarily. We don't give advice that teach people to overprotect their bodies, because the health of the back is about movement and activity and engaging in a healthy lifestyle. That is about the health of the back. And we actually teach people to do the opposite.
Over the years, I've learned that movement is healing, right?
It is. It's not your enemy. It's your friend.
Although we're sort of honing in on the back at the moment, a lot of these principles also apply, I think, for other chronic pain syndromes.
Absolutely. Any persistent pain, it's the same story. Be it knee, shoulder, neck, hip, it's the same story.
Yeah. A few years ago, you and some of your colleagues published this beautiful editorial in the British Medical Journal.
Yep.
Back to basics, 10 facts every person should know about back pain. Now, I wonder, you've mentioned that a lot of the beliefs people have, doctors have, society at large has around back pain, a lot of those beliefs are not founded on evidence and you think are downright wrong.
And harmful.
And harmful. Okay, so in this editorial paper that you guys published, there are 10 myths. Can we go through them one by one and get your commentary on them?
100%.
So I think this would be really useful for people. Okay, myth number 1, lower back pain is usually a serious medical condition.
Yeah. So what we know is that about 1%, like 1% might be associated with some kind of underlying pathology.
Like a malignancy, cancer.
Yeah, 100%. Yeah. Fracture, cancer, quarter equine syndrome, where there's compression of the nerves that supply the bladder and bowel area. Like, there are things we can't miss as clinicians. So we need to screen for them always. That's the minority. And actually, primary care clinicians like myself, we will see them, but they're not very common.
And here's the problem, Peter, if I think about how we're trained, right? We're trained to not miss the serious things, right?
Yeah, which is really important.
It's really important. But if I just think this through logically, okay, so because the serious things, it's the same thing with headaches, frankly. Someone comes with headaches, we're always doing what we call our red flags, making sure there are no red flag symptoms, which indicates this could be something much worse than a tension headache or much worse than just musculoskeletal backache, right? So we're also practicing in a culture where defensive medicine prevails. We're all scared of getting sued. So therefore, we have to be damn sure we haven't missed the serious thing, which
really important.
Which is important, right?
Yeah.
But because that's where the main focus of our training lies, we're always going to be biased in the consultation to going, oh, this is not cancer. This is not a fracture. Okay. But we're not given the same amount of training and attention on, for the 99% of them, which isn't those conditions, we're not given the same level of training around them. Do you get me? So it's 100%. It's a self-perpetuating cycle.
Yeah, of course it is. Because it's not very reassuring for you. Well, if you're frightened that you've got cancer, knowing you don't have it's really reassuring. But if you've got debilitating back pain, like you had, and you can't pick up your child, you can't do stuff that's important for your life, you can't engage in healthy lifestyle activities like engaging with movement, and you're told, well, at least you don't have cancer. That is not helpful. So you're kind of left. Once the serious stuff's excluded, you're either then scanned and given a faulty explanation, actually, which is probably number 2, around being given a misdiagnosis.
But let's just expand this out of back pain just for a minute, Peter. I think this is one of the major problems in medicine today, right? Let's take chest pain. Acute chest pain, right? A lot of the time, a patient with chest pain will end up in A&E or the emergency room, depending on which country you live in, right? And it's not uncommon for you to get investigated. Primarily, they're looking at your heart. Is this a heart attack? Is this angina, right? Because you need to know that. Because if it is, you need quick, immediate treatments. But the amount of patients over the years who I've seen and any doctor will tell you this, that the patient went in with chest pain to A&E, they weren't told what it was.
No.
They were just told this is not a heart attack.
Yep.
Go back to your doctor.
Yep.
Go back to your GP.
Yep.
Right? And again, I understand,
Yep.
it's an emergency treatment center. They have to prioritize what they're seeing. But it is not uncommon that people with chest pain go around the houses.
Yep.
They go back to their GP, then they get referred to a gastroenterologist who says, "Oh no, this is not gastro." Go back. We love to put these things in little boxes as if they're separate, but they're not.
100%.
Right? It's all related. And so let's go back to myth 1 again.
Yeah.
The myth is that lower back pain is usually a serious medical condition. You're saying that's not true.
It's
99% of the time, it's not.
And look, there's another group of people who may have a disc prolapse, for example, like some disc material that compresses and irritates a nerve. That's another small group.
Is that about 5%?
Yeah,
I think?
exactly. But the majority of those get better. The body is amazing. We can talk about that later, but those discs reabsorb. For the majority of people, they reabsorb. The body does it itself. So a lot of people think, oh my God, you've got that. That's for life. It's not for life. The studies have scanned people at baseline and 6 months later and gone, disc gone. Like that prolapse is gone. Well, the majority of it, like you said, it's around 95%. We can't pin the pain on any pathology. And so we shouldn't. And we need to look way beyond the structure to understand pain. And that's what you're highlighting is not done well.
Yeah. Well, myth 2 speaks to this. Lower back pain will become persistent and deteriorate in later life.
Yeah.
You're saying that's completely false.
Yeah, and I think there's a perception of doom often, and this is why I mentioned hope at the beginning, because we see people who they go, if I've got this at 20, what will I be like at 50? I will end up in a wheelchair at 60. There's that perception that if it's this bad now, it can only get worse. And in fact, what we know is that back pain can be effectively managed at any age, often, and particularly in later life. If you scan anyone over the age of 60, you will see in 80% of people, disc degeneration, disc bulges, so-called arthritis. These are normal age-related changes. We call them pathology. We start labeling them as the cause of pain. It's not true.
Well, let's jump to myth 4, right? Because it speaks to this. And I think this is huge. I think this is a problem that's getting worse.
It is, yep.
Whilst initially people might think scans are a good thing, I think for so many people they cause more problems.
Yep. The MRI has created a massive issue for people with back pain.
Right. So we're going to talk about that. But myth 4 is scans are always needed to detect the cause of lower back pain.
Yeah.
You're saying that's false.
Yep. So that's true for the serious group we talked about, malignancy, cauda equina syndrome with the compression of the nerves.
A scan is helpful in those.
Really important.
In that small minority.
Really important.
Now, a layperson may be listening, Peter, and go, okay, but how the hell are we meant to know if it is that unless we do a scan?
Yeah. So that's why you have trusted healthcare practitioners who can screen your story, your history. They can look for the key features because we know there are key features that will be predictive of that. And that's why you need trust in your healthcare practitioner so they don't steer you down the wrong path. Now, there's no danger in a scan. Like an MRI scan in itself is not dangerous. There's no radiation exposure. But the report is where the problem comes.
It's not only the report,
and the interpretation
and the language
massive
that
issue.
we use as healthcare professionals when we communicate that
massive
is huge.
issue. Massive issue.
Right? So let's just make this really straightforward for people, right?
Yeah.
So someone's got persistent lower back pain.
Yep.
Right? It's not getting better.
Yep.
So they're going to keep coming back.
Yeah.
Let's say to their doctor, going, look, I tried that. I went and saw the physio. I've still got it. I can't work.
Yeah.
Hey, doc, I need a scan. I need to know what's going on.
Yeah.
That's very, very common. And to be fair to doctors as well, a lot of doctors, particularly in a system like we have in the UK, like the National Health Service, I think it's different in private healthcare systems. But we're very much schooled in British medical schools. We're very much trained to only order tests if they're going to change our management.
Yep.
So I don't think in this country, historically, we over-order, whereas in a country like America, which is a private system.
Australia's like that too.
I think people are getting way too many tests, investigations, and scans, right? But I think sometimes the doctor will think, this is musculoskeletal backache. This is not cancer. It's not a fracture. I can tell from the history and the examination. But the patient needs some reassurance. So reluctantly, they order a scan.
And that's okay if you interpret the scan properly.
Okay.
That's the key.
Just taking a quick break to give a shout out to Vivo barefoot shoes. Now, I've been a huge fan of Vivo barefoots for over 10 years now, well before they started supporting my podcast. They are the only shoes that I wear, and they really have had a huge impact on my own life and the lives of many of my patients. You see, when people start wearing minimalist shoes like Vivos, you can see improvements in things like back pain, hip pain, knee pain, foot pain. Even things like plantar fasciitis can often get better. And scientific research shows us that just wearing Vivos for about 4 months or so improves the strength in your feet by over 60%, which is absolutely incredible. One thing people don't realize about these shoes is just how flexible they are, which allows your feet to do what your feet naturally want to do rather than the shoe dictating your foot's movement. Vivo Barefoot are giving my audience a 15% off one-time code when you make your first order, and they make it really easy for you to give them a try. They give a 100-day trial for new customers, so if you don't like them, you just send them back for a full refund. I'm a huge fan. I really hope you take advantage of this offer. To get your 15% off codes, all you need to do is go to vivobarefoot.com/livemore or click on the link in the description box below.
Can I just explain a beautiful study that was published? Yeah. It took a group of people with acute low back pain. It scanned all of them, MRI scan. One group was reassured. This is normal age-related changes. And what does that mean? Well, we know that even at the age of 21, about 40% of people will have so-called disc degeneration. About 20% have disc bulges. These are just features that you see on a scan. These are people with no pain. At the age of 40, 80% of people will have degeneration, which is an unfortunate name. It's just the name that's been given to a reduction in water content in the disc. 60% have disc bulges. 30% have protrusions. These are in people without back pain.
You say unfortunate name.
It is unfortunate.
It's not only unfortunate, but you could argue it's downright problematic.
It is.
Right?
100% it is.
Because it's not neutral.
No.
If you get told, as I did, as many people do, in your 20s that you have a degenerative spine, what does that do to your belief system about your body, your spine, your ability to move forward in the world?
Massive.
Right?
It's massive.
I quoted you a statistic earlier on, right? 70% of people in developed countries will get lower back pain at some point in their lives. Developed countries. We know that there are some countries and cultures where they don't get backache. Or they get less. There's a lower incidence.
I think there's a difference between backache and disability, and we need to separate those two things out. We don't have number one, we don't have great data in some lower and middle income countries. But there was a recent paper came out of Brazil, for example, that showed that back pain was a really common problem there and also disabling. If I was in Nepal in November, December, trekking around the Everest region, those people are extraordinary, carrying these massive loads on their body. They can't afford, they have no social security. If they don't function, they don't live. They don't eat. They can't survive. So in a sense, back pain is a common human experience. Disability is something else.
That's interesting, isn't it? Because that also brings in the idea of the brain, right?
And beliefs as well.
And beliefs.
Yeah.
And we were chatting before about my conversation maybe 2 years ago now with Howard Schubiner, who also does a lot of great work in chronic pain, and his belief that the brain creates this neural circuits, and if we get scared and We have fear, and I know we're going to talk about that as well, how they can create these self-perpetuating loops in the brain. Even if there's nothing physically wrong, like emotionally, that can drive pain. But if we think about what you were saying in Nepal, and we think about belief systems, well, maybe they're not complaining of backache, but maybe they're experiencing discomfort, but it's like, well, so what? I've got to work. I've got to feed my family. So I don't have an option of calling it something or labeling it something. I just have to crack on.
They do. Yeah, they do report back pain and backache, but they don't have, like you said, they have to function. They have to go out to the field. They have to lift the loads. So, they don't have a choice. We've in a sense, what we've done, I think, in our culture, and that's high-income country societies, is we start scanning, like we said, we start scanning people. We tell people they're damaged. We then frighten them. We give them advice that actually makes them overprotect their body. It sets them up for failure. That doesn't happen in the Everest region in Nepal. There isn't an MRI scan up there.
Do we know, or do you know, if hunter-gatherer tribes have been studied for backache or their backs have been even scanned?
I don't know. I know there was I know a little bit about some research in Africa. There was a study done, this is going right off piece, but, the women who carry these huge loads on their neck, and they looked at whether, the load was actually detrimental for their spine, and it wasn't.
No.
Like, the spine is designed to load. They had stronger necks. If you look at Asian countries in the paddy fields, how do they lift? They stand with their legs straight, fully flexed. And in Africa as well, they don't have ergonomic, advice. In fact, they're unloading their back when they're standing, where they've got like these long hamstrings and they unload their backs. It's probably really protective. We've done something else. We've told people to, keep their back straight and bend their knees. They don't do that.
Yeah. Why I think it's really important is that more and more, I can't get away from the idea that our behaviors are massively driven by our beliefs.
Massively.
Right? But we don't realize we're living within our beliefs. Yeah. So sometimes we can't step outside them to question, well, where do we get that belief in the first place? Yeah. Right? And what would happen if I never adopted that belief?
Yeah.
Right. So maybe in Africa, like
100%,
they believe that, we're strong. We can carry big, heavy loads of water and whatever else with a straight spine, and we're going to teach our kids to do it, and there's going to be no problem. And we have to keep doing it, because if I don't do it, no one else is going to be there to do it for me.
It's true.
So
there's truth in this. And look, part of our population research looked at this question in Western Australia and young people. We looked at their beliefs about back pain. And we looked at, whether they believe back pain is something that they should be careful with, whether it's going to get better over time. We found there was a general negative belief system in those young people. This is like the age of 15, 16. And when we looked at the likelihood of those kids taking time off school, of avoiding movement, backing out of physical activity, taking medication for their pain, they were more likely to than the kids who had a positive belief about their backs. We then looked at the parents, and we showed that there was a relationship between parental beliefs and the child's beliefs. So we inherit our beliefs from our parents, and we often model that. So if the parent's taking time out of school, off work, seeking care and avoiding movement activity, the child is more likely to. And that then fast forwards into their work life. So if a kid's taking time out of school, the adult's more likely to take time off work. So, and we can't blame people for this. It's normal. Like it's normal.
This has, again, broadening this out, the way that we inherit or learn our beliefs.
We learn, yeah.
Especially as kids, in the environment in which we grow up. So for many of us, from our parents, like, yes, it can be about back pain behavior. What do you do? Do you take painkillers? Do you not? Do you keep moving or do you stop moving?
Exactly.
Do you take time off work? Do you not? Right?
100%.
You're going to get those. Same thing applies to food, right? Our eating behaviors.
100%.
What do you do in times of stress?
Physical activity.
physical activity, how do you soothe emotional discomfort? Is it with ice cream and sweets, or is it with something else? You will often learn that from your family and how they did it. So, I find this absolutely fascinating.
So interesting. Yeah.
Just going back to these tribes for a moment.
Yeah.
I want to get back to scans because I think
no,
it's fine. This idea that it's normal to have degeneration in your disc, right, or degeneration in your spine, and I know we probably don't love the term degeneration.
Yeah.
What I'm trying to get to is, I wonder what people who live different lifestyles to us, if their backs were scanned also at the rate our backs were scanned, would we see that sort of degeneration as well?
I don't know.
Yeah, it'd be interesting, isn't it?
Yeah, it is. Look, those studies haven't been done. But, the thing that amazes me in my work is that I see people with some of the worst looking scans who can become pain-free relatively and get back to doing all kinds of stuff in their life. That's the hope bit. And that's the bit that we don't share. And I think as clinicians, we become frightened as well. Oh God, with that back, you really should think of another job.
Yeah.
In actual fact, loading your back makes it stronger.
Yeah.
Moving your back makes it healthier. And if you do have changes on a disc, it doesn't define your future.
Yeah, this is a massive point, right? What your work is fighting against is decades of so-called truths that are permeated into culture, where people just say this stuff.
Health culture and general culture.
As if it's real.
Yeah.
Right? So, okay. Now, I would say I was very lucky back in, I think, 2003, 2004, because that was sort of 3-4 years into my journey with back pain, and I was trying everything, going here, going there. I had to take a period of time off as junior doctor when I was working in Salford Royal Hospital. And I had a scan done, and I think the surgeon's name was Mr. Ross. And I always remember this because what he said, I don't think I realized till this morning how much it may have influenced me.
Yeah.
But he said to me, there is a disc bulge at L4, L5. But Rongan, let me tell you, if I was to take 100 people off the street now of your age and I scanned them, I can't remember the statistic, but essentially over 50% would also have a disc bulge like you.
Yep.
And most of them would not have pain.
Yeah, exactly.
And
it's hugely reassuring, right?
Hugely reassuring, because it made me think, because had he said, you got disc bulge, that's probably the reason you've got this pain.
Yep.
My belief at that point would have been, I have a disc bulge, that's causing my pain.
I need to be careful.
I need to be careful and protect that, right?
Yeah.
But because he didn't say that, that just opened the door in my mind to go, well, wait a minute. So I've got a disc bulge.
Yeah.
But he's saying that may have nothing to do with my pain. And he also said, and this is about 2003, 2004, he said, Rongan, the problem is that these scans are static as well, right?
Yeah.
So it's just telling me a snapshot at that moment when you're not moving. Okay. Ideally, I'd love to see a scan where you're moving, and then I could maybe get a bit more information. So let's go back to the scans that many people are asking for and getting.
Yeah.
You're saying, I think, Peter, that many people are being told that a bulge or a bit of degeneration in the spine is the cause of their pain. And you're saying in most of the case, it's not.
Well, I'm saying that it doesn't define your future. So you can have a painful disc, but it doesn't mean it's going to define your future. So there are studies that have looked at this. So I'll come back to the probably 3 key studies.
Yeah.
The first one took this group of people, they scanned them all. One group were told what you were told, normal age-related changes. Didn't give them the descriptors, just normal for your age and people without pain. Don't worry about it. The other group were given the detail. You got a degenerate disc at L4-5 and a bulge and some arthrosis and a bit of a fissure. They were given that information.
Doesn't sound good, does it?
No, it's terrible. They followed them up. They didn't control anything they did. They followed them up. 6 weeks later, the people who were given the scary information, their pain was worse, they were more disabled, their mental health was worse, their function was worse, Those who were reassured, their pain was less, their function was greater, their mental health was better. That if there was one study that shows the powerful effective messaging of a scan is that. Now, if there is a dysbulge and it's compressing a nerve and you've got neurological deficit, that is relevant. That is relevant. But a dysbulge in the absence of any nerve compression is just a normal feature on your spine.
But that's such an interesting study because it really speaks to this idea of beliefs.
Yep.
For any clinician listening or
so
watching
important.
right now, your language matters. What
Massively.
you say to a patient absolutely matters. Do not give offhand comments, without thinking about it, because people take on those comments, they become their beliefs, and that then influences their behaviors.
Massively, And it also starts guiding the clinician as to the advice they give. Because if that's the clinician's advice, and look, the sad thing is that we're not well educated. A lot of our professions are not well educated in this. They've got old thinking, and then they start giving advice of telling people not to do sport and lift things and play with their kids and, lift heavy, go to the gym or whatever they're into. That in itself has a massive feed-forward negative consequence in their general health.
Okay, so let's say someone's got backache and all the red flags are excluded. It's deemed to be, I was going to say simple, but it's deemed to be...
It's non-pathological back pain.
Okay, so
let's call it that.
Non-pathological back pain that in most cases will get better naturally.
Within a few weeks.
Within a few weeks. Okay. So that person has got backache. They've been reassured it's not cancer or a fracture. They're like, okay, great, I can crack on with my life. But when I try and lift my child or bend down to play with them, I get pain.
Mm-hmm.
What are you suggesting they do at that point?
Yeah. So if that is an acute presentation, so we would take people through, number one is screen them.
What does that mean?
Oh, make sure we haven't missed anything.
Okay.
Yep, that's
fine.
That's,
so
that's
make sure we haven't
right?
missed anything serious.
Yeah.
Okay.
So take the history, has there been an injury? No injury. So what was going on for you at that time? That's so important. History is so important because, I think of a recent case of a lady who I saw and, her pain, and we know this from the research, as we said earlier, it's often at a time of stress. The person's not sleeping well, they're run down, they're tired, they're tense, they've got other stuff going on, they haven't been caring for their health, pain emerges, right? We say that's a message from your nervous system to care for your health, to, learn to relax your body, get it moving, get good, healthy sleep, re-engage in physical activity, get gentle. We can do it in a graduated way so that you're not just forcing people to move. You start in a very graduated way. And that's why practices like yoga, simple, basic foundational movement then builds on function. That's where we would take them. So we kind of, what we call we grade people back up into function with the belief that their body will recover.
So the goal is to get them back to function.
100%. Quickly.
So if someone a week after their first acute episode is unable to do certain things like lift their child or bend down and play with them, right? Then your approach and
coach them.
You publish loads of papers on this, right? Which we're going to talk about.
Yeah.
You would almost say, at the moment, that's fine. Okay, it is. You recognize it. It's causing you discomfort at the moment.
Yeah.
But let's not allow this avoidance to continue 100%. For too long.
Yeah, 100%.
Because that then becomes your new norm.
Yeah,
You're then
exactly.
avoiding.
Yeah. So if you take an example of a sprained ankle, for example, you wouldn't go running on it the next day. So if the person's had a lifting, twisting incident and, loaded their back and they've sprained their back, you wouldn't say, look, just go back to lifting tomorrow. Yeah. But you would say, look, just get yourself moving. Don't do heavy lifting for a couple of days. Get your movement back, relax your body, build your confidence back, gradually build up your ability to lift, and then get back into it. But the key thing is what triggered that event. That's what we look for, because it's the understanding the factors. Because what we know is that lifting in itself may be a trigger, but if you're stressed and tired and run down, that's a much greater chance of it happening.
Yeah,
does that make sense? So it's all these combination of factors.
100%. I mean, and then if we zoom out, and look at the state of society and go, well, wait a minute.
That's our society. It's a cocktail.
Back pain is on the rise.
Yep.
Stress and burnout is on the rise.
Yep. Inactivity is on the rise.
So it's almost like the perfect storm where people are going to get pain and discomfort.
Yep.
But too often, I guess we just focus on the pain.
Yep.
Understandably, because it's hurting.
Yeah.
But we don't look at this holistically and go, would that lifting injury that you may have got when you lifted and twisted, an acute back sprain, would that have happened if you weren't overrun in your life, working too hard, not sleeping
We know
enough?
the chances are way less.
Yeah.
We know
you have
that.
more resilience.
100%.
You know, it's, again, trying to just draw patterns in from other work. It's not quite the same thing, but if you get exposed to a traumatic incident and you have had, you know, a really stable childhood upbringing, you've got support and community in your life, and you had it as a kid, that's less likely to become PTSD than if you didn't have that, than if you had early childhood traumas, and if you don't have community and support in your life, right? So the same insult, but the impact of that insult depends on all those other factors.
Massively. And we know that's the case with pain. You know, taking an example of like motor vehicle accident, for example, we know that the key predictor of your response to that injury will be your stress response, how you respond. It's not it's not the size of the crash, it's not the damage done, it's your body's stress response. So if you freak out or you panic, or you'd have like a potent emotional response, you're more likely to overprotect the body, and the nervous system response will be to create this massive sensitization. So we know that the same factors are in play. You know, we know, for example, early life trauma is an increased predictor of, as an adult, of you having pain in the body as well. So there is this kind of cross-link between all these factors. And that's why the history is so important. Because, you know, what we know is a lot of people are rocking up in EDs with non-traumatic back pain. No one's screened their history. No one's taken their story to understand why they have these terrible episodes of pain in their life that debilitate them and frighten them. No one's done that. We need to do that as healthcare practitioners to help people understand what the meaning of their pain is, and then to set them on a path for recovery.
You're a physiotherapist, right? A lot of people in the UK who have chronic back pain and end up seeing their doctor, certainly within the NHS, will then be referred on to physiotherapists. So in theory, physios have expertise in this area, perhaps more expertise than, let's say, the doctor referring them. Do you think, as a profession, physios are more aware of the biopsychosocial elements that contribute to backache?
They should be.
Or do you think it still hasn't moved on much and it's still deemed very much a mechanical issue?
Look, I think there's a veneer of understanding. I think in some quarters there's definitely an understanding. I think the understanding is one thing. Changing our own practice behaviors is something else. I think that's really hard to shift. And we've seen this in our research as well. Like, I could ask you, well, what do you think about back pain? And you go, oh, well, you know, backs need, you know, it's good to move and you shouldn't be fearful and re-engage in healthy lifestyle. And then someone comes in to see you and they got a disc bulge. You go, well, you better be careful when you bend over a lift. Like, we see this kind of human beings have got all these kind of mismatches between our own beliefs and behaviors. And so part of what we've been involved with is with our research is actually training clinicians in their own to shift their own beliefs and behaviors so they can support patients. Because if you don't, you know, we know that most of our educational interventions for clinicians don't change their behavior at all. Amazingly.
Well, that's really interesting, isn't it? So why is that, right? So is it because a physio or a doctor is taught how to practice when they're at physio school or medical school, right?
Yeah.
When they're doing their training. And they get used to practicing a certain way, right?
Yep.
So they have a system and how they do things in the time that they have allotted to them.
Yep.
And then they might hear something new and novel. They may read some research. They may read some of your research or watch one of your lectures online and go, oh, wow, I didn't realize, what Professor O'Sullivan has published. That's really interesting. Yeah, that would affect my patients. But then is it too hard sometimes to integrate that in to their existing way of practice? Is that what you think it is?
Yeah, I think it's a whole bunch of different things. I think that's one thing. So like part of the trial, which we'll talk about later, I think, we took a group of 18 physiotherapists and we took some who were 2 years out and some who were 30 years out.
Of training?
Yeah.
Okay.
Yeah, post-training. We found the younger ones were more able to adapt. Actually, the older ones found it really tough.
Yeah, I can believe that.
Because of they had their confidence was linked to a whole way of working, and they felt like we were unraveling them. But over time, they could change. The training program took 6 months. We would take them in once a month, and then we would get them to work with people with back pain. So real-time stuff. And we'd give them feedback around their own way. What we noticed is we'd film it and then we'd get the clinician to watch themselves and they would go, I didn't know I did that. I didn't know I said that. I didn't know I messaged that in my consult. It just was automated. And so, some of it probably comes down to our own personal pain beliefs about what we're comfortable with. It comes down to distress because, you, with your experience, pain is scary and distressing. And if we don't feel comfortable with that distress, and often it's deeply emotional and patients will break down and cry. And if we're not comfortable with someone's emotion, we will shut it down. And we see that as clinicians, we shut it down. And that's a missed opportunity. But also with the body, we have these rules. And so we start telling people to hold themselves this way and do this and do that and be careful and become we create hypervigilance in our practice. So there's so many elements which we have to untrain and retrain, I think, healthcare practitioners to change the way they think and behave to support people with pain.
You seem to be someone who quite naturally looks at a patient and their pain and tries to contextualize it. You try and figure out, well, why is this happening at this moment in this person's life?
100%.
Right?
Yeah.
I've always had that inclination as a clinician as well. It's why? Why now?
Yeah, exactly.
What's going on? What are all the factors?
You've lifted for this many years. Why this lift?
Exactly.
Yeah.
Yeah, exactly that. Yeah. And for years, I never thought about how I lifted.
Exactly.
But I felt I was pretty strong and able to lift a lot of heavy things.
Yeah.
Right? Now, I think I heard you say this in one of your online lectures. Did one of your colleagues at one point say, you're delving a bit into psychology now. This is not physiotherapy or something like that? Yeah. Can you just share that a little bit?
Yeah. So we kind of look at, if we think of the person with pain, living with pain, pain is deep. If it's persistent and it's disabling, it's deeply emotional, right? So if you're a physiotherapist and you don't deal with emotions, you shouldn't be working in that space. It is a fact. So what's happened, our profession has kind of evolved from a very biomechanical, exercise-based structural paradigm, but it works very closely with people with pain. So if we're not interested in people's emotional experience, we shouldn't be working with them.
Yeah.
So there's a gap in health. We have psychologists who are not trained in pain, and we've got physiotherapists who are not trained to deal with people's fears and emotions, and the poor patient is left sitting in the middle.
Don't even get me started on this. This is what I fight against my entire career, and particularly in the public facing work that I do. We are these three-dimensional beings, right? You can't just have your psychology dealt with a psychologist and your biomechanics dealt with a physiotherapist and your annual cardiac checks done by the doctor. It doesn't work like that. We don't work like that.
No.
To make sure you're taking action after watching this video, I've created a free guide to help you build healthy habits. We can all make short-term change, but can those changes become a fundamental part of our life? Often they don't. And that's why in this free guide, I share with you the 6 crucial steps you need to take. They're really, really effective. If you want to get hold of that free guide right now, all you have to do is click the link in the description box below. And I don't understand how you can be a good and effective clinician without delving into psychology.
You have to.
You can't. It doesn't mean you know as much about psychology as a psychologist. It doesn't mean that there isn't a role to refer. No. But it means that we have to be able to cover that side of it. And you have to get some confidence at dealing with that, or you're going to be very, very limited.
And look, back pain is an embodied experience.
What does that mean? For people who don't understand that, what does that mean, embodied
So it's not
experience?
just in your head. It's like, for your experience, you felt pain in your back muscles would have clenched up. You would have been super sensitive if I touched the structures in your spine. That's a real local tissue sensitivity, right? So that's real. Like, it's not something in your head. You didn't make it up. They're local tissues that are super sensitive to touch and to movement and to load. That is but fear and overprotection can drive that.
Yeah, I
do you understand that?
100%. Yeah. I overprotected my back for years. I was scared of it. I felt I was weak, and at any point the back could go. Yeah. So I started to contract my life.
Massively. Yep.
You wouldn't put yourself in positions where you knew this was even a possibility.
Yep.
Oh, I can't do that. Oh, I can't go there, guys. It's too long. It's too long a drive. Gave up playing squash. All these things, and just to really highlight that biopsychosocial element of pain, or the way I like to frame it for people, and I think this applies to any chronic condition, whether it's a chronic disease or chronic pain. In my experience, it's very rarely one thing. Right?
We know it's not.
Yeah, I've never seen
back pain. It's not.
But back pain, type 2 diabetes, autoimmune disease, it ain't one thing. It's a combination of factors.
100%.
Genetics play a role. Lifestyle plays a role. All kinds of things play a role. And that concoction together over time results in the phenotype that you express, in the pain symptoms or the disease that you have. Right. So, and I know you've got a lot to say on this, but one of my frustrations sometimes with the way we use science to help us or to help educate us to help an individual patient is that there are so many factors going on with any individual patient, but a lot of science, not all science, but a lot of science tries to isolate down to one factor and just measure that, which is useful.
It doesn't tell you much, though.
It doesn't tell you that much, right? But you've got to address multiple factors. So
exactly.
For anyone who didn't hear my conversation with Howard Schubert, let me just give a brief synopsis of my journey with pain, right? Which was, it started when I was about 22, 23, never had it before, ever. Was helping my flatmate, Mary, at the time, move into our new flat, lifting boxes up 3 or 4 flights of stairs all afternoon out of a car.
Yep.
Suddenly, with one box, it just went. My back just went for the first time in my life, dropped the box, lay on the floor in agony, and that is when it all started, right? Now, I don't remember the exact thing that happened in the hours afterwards. Howard asked me what happened in those immediate hours. I can't remember.
Yeah.
But I would have gone to see my doctor. I would have taken painkillers. I would have, and I know I did see a physio. And I tried everything, right? Like people do. I spent a lot of money. Physios, chiropractors, osteopaths, and all of them. I'm nothing against those professions. I think there are some fantastic people in all of those professions. But I found that it was only part of the problem. It would give me, it would help me for a few weeks, and then then it would come back. Now, one of the most significant things that happened was in maybe 2011, 2012. I came across a guy called Gary Ward, a biomechanics specialist. It's phenomenal the way he looks at the human body. And I went to study with him and went on his courses. And again, I don't want to misrepresent Gary's work, but one of the things that I learned was that my right foot wasn't working as well as it could do, right? And Gary wasn't necessarily saying that. He was looking at my entire body going, Ron, your right foot, it's flat, but it's stuck in pronation. Pronation is actually normal, but you want to be able to come into it and come out of it. At the moment, you can't. So he did some exercises with me, very simple. Immediately, I started doing those about 5 minutes a day. I could feel my back starting to loosen, right? Okay, so I thought, I'm on a winner here, right? And there's no question that significantly helped me. I got back to everything, squash, long drives, everything. But there was still this discomfort there, right? There was an awareness. Sometimes it wasn't there, but I wouldn't say it was fully gone. And I know you heard my conversation with Howard, so you've heard this story, but one of the most powerful learnings I've ever had about pain was at my dad's funeral.
Yeah, I heard that.
Right? And I was a carer for my dad for many, many years, a huge part of my life. When Dad died in 2013, he got cremated. At the end of the service, obviously, moving service, very emotional, right? I was very, very close to my dad's. We came out of the crematorium and we were outside at Manchester Crematorium and watching Dad's coffin go into the flames, the oven. You could see the orange flames. And it's not as if I was thinking about my back. I was just present for the experience of my dad's body about to be burnt. And I remember Dad's coffin goes inside into those flames and my back just eased off completely. That happened. I know that happened, and I have reflected on that in the weeks and months afterwards. And I got it. I was like, the weight of looking after Dad for this many years.
That's the embodied.
That's the embodied. That's not my conscious mind. That's my subconscious mind.
100%.
And it is, although I've told this story once before on the podcast, it is amazing to me to think that is how powerful our mind is. Where it saw that my Dad's body is about to be burnt to ashes. That gave it the evidence, you don't need to do this anymore.
The pressure's off.
Right? So that fits into my model of health, which is very much, there's multiple factors.
100%.
There was a mechanical issue, right? Which Gary helped to improve. And now Helen is helping me improve massively, right? But there was also an emotional issue. It's not one or the other. 100%. They were both involved.
But a good clinician should be able to tease both of those factors out.
And you teach clinicians how to do this.
That's what we do,
Tell me about this. You've got this kind of social enterprise running, haven't you?
We do, So, look, the Restore trial was a kind of like a critical...
Is this what you publish in The Lancet?
Yeah, that's right, So we'd had a number of small trials in different countries, one in Ireland, one in Norway, that had demonstrated the effectiveness of this intervention, which we call cognitive functional therapy. We had to come up with a name.
I like it.
And the F is so important because it's about the behavior. So CBT, which is cognitive behavioral therapy, is what a lot of psychologists will use around thoughts and behaviors, which are great. The F bit's about the function, about the back, the body, the whole body. And that's sort of what you're tapping into. And that we look to the body, we explore, the confidence in the back, the ability to move, to relax the body, to build safety back in the body. That's one of the key elements of this intervention. So the trial was based in Australia. It was a 2-center trial. We took about 500 people with long-term disabling back pain, more disabled than most people in trials. Lots of back pain trials exclude people who are really bad. We included anyone from 18 up to into the 80s. We had no top level, so we wanted to be very inclusive. We had people who had had pain for over 4 years and who were more disabled than most. We took a group of physios and we trained them over 6 months. I mentioned that. And then they took the patients through this journey, which essentially was the first thing is to hear their story, and often people were saying, no one's listened to my story. You're the first person through this whole journey to actually listen to my story, to validate me, to help me understand that actually I'm not going crazy, that this is a real experience, that your pain is real, that the impact of pain is huge in your life, but let's build hope back. You know, let's understand the factors that are relevant for you, and they're different for everybody. So, and then let's personalize the program. Let's understand your confidence in your body. Let's have a look at your move. Let's look at the things you can't do. So, you know, if it's picking up your kid, we want to look at that. If it's driving, we want to look at how you hold your body in a car. If you want to get back to running, we want to look at how you're using your body when you load a limb, when you transfer load. So we kind of break all those processes down and then take people on a journey to help them understand that actually pain is modifiable.
Right.
That to build, you know, like an optimism back around their body through a process of learning to relax the body, re-engage in normal movement. We break all the posture rules and we target the things that people value. So we, you know, it's not prescriptive, it's individualized to say, what are the things you want back in your life? Play tennis, pick up your kids, travel. They're the things we're going to target. And that's a moving target because often when people get them back, they want something else. So that's like a 3-month process that we coach people. We're working as a coach to build the confidence back, help them understand the drivers of their pain, be it emotional, be it thoughts, be it behaviors, which often it's a combination of factors, be it other issues around their lifestyle, around their sleep, around their diet, around engaging in physical activity, to realize that actually there's this whole capacity that they have to regain health in all aspects of their health, actually. And that's what the qualitative studies have shown us, that people have said, look, this was great for my back, but actually I'm sleeping better. I've now lost weight. I've changed my diet. I'm back into work. I'm doing stuff I thought I couldn't do again. And my mental health is better. So it's never just about the back. It's about all of these factors. And I think, you know, people with pain get that. They get it when it's almost like they get lost in the maze of the health system. And a lot of these people had literally given up. They'd had so much treatment, a bit like yourself. They've been scanned, they've been given stuff, and they've literally gone failure, failure, failure until the point they've just given up. And that's so sad that we've got people living in our society who have literally given up on healthcare because they think there's nothing left. So that's the journey that we took those people through. And then we followed them up, you know, like 12 months later. And so getting back to the social enterprise.
But what did the results show 12 months later?
So literally what we found is that was compared to usual care, and they could have anything they wanted.
Right.
A lot of them had given up on care, and about 60%, 58% were on medication. Around 28% were seeing a variety of different people. We found significant reductions in their disability. The key thing was it wasn't just after the treatment. It actually continued to improve 12 months later. Yeah. We've got unpublished data showing that the improvements are lasting out to 3 years.
I mean, that's what we're really looking for.
That's what we're interested in, right?
Yeah, because one of the critiques of a lot of trials is that, it only lasted 4 weeks.
Exactly.
It only lasted 8 weeks.
Most back pain trials show that.
Yeah, so that's the key goal for me, which is, 12 months later, 3 months later. And I imagine...
That's what excites us about this. It's an empowerment model around giving people the tools to self-manage their own pain condition. That's the key. It puts them in the driver's seat.
And the medical model is a disempowerment model, isn't it?
Yeah.
It's
let me fix you.
Yeah.
Let me do something to you. And I got trained in that. I'm a manual therapist by training, where I was trained to do stuff to people to make them feel better. And what we know is it doesn't last.
I teach clinicians. I have this training course, Prescribing Lifestyle Medicine, that we run online to clinicians all around the world. And one of the things I'm always keen to teach doctors is you have to give your patients a sense of agency.
Massively.
They cannot walk out the door feeling that only you have the tools to help them.
You know, manual therapy is really stuck in that. It's like my magic hands can do something to you that makes you feel better, but you have to come back for more.
But again, it's not either or, right? It's like,
of course not.
Clinicians and experts have lots that they can help patients with, but the patients also have to be
massively
shown what they can do as well. It's not either or, it's together.
Yeah, of course it is. And that's why there's a lovely kind of descriptor of the clinicians. They described it as this learner, the training journey is a learner-driver model. But the journey for the patients is a bit like that as well. It's like you're co-driving at the beginning. You don't just chuck someone in a car and say, look, here's the manual, off you go. You coach them. So you're sitting with them. And this is what we saw in the trial, is that we're working very closely with the patient in the first, the person with pain in the first couple of weeks. And then we might see them in the 2 weeks later, and then it's 3 weeks later, and then it's 4 weeks later, and we're chasing up their goals. We're building confidence back in them. We're giving them strategies to re-engage in stuff. We're getting them back to, doing stuff they love, which is very motivational. When you're getting stuff back, you want more of it. When you're losing stuff, it's very unmotivating.
Yeah.
And so that's a partnership. And the qualitative studies have talked about the importance of trust in the clinician, that that trust is so important. It's a bit like, doing something like back pain's scary. So it's a bit like being on rope with someone on a rock face and knowing that your instructor's got you. They've got you, and it's okay. You're safe with me, and we're going to teach you and coach you and build your skills. We're not going to push you too hard, but we're going to get you back to doing the stuff you love. That's a process, and that process can be really quick for some and really tough for others.
So you're teaching this model to clinicians around the world?
Well, what we've developed is a social enterprise where we've been literally, since the trial came out, we've had inundated with people saying, we want to know about this. And
people like healthcare professionals?
100%.
Physios, doctors.
We also get contacted by patients as well, saying, I've read this. This resonates with me. That's my story. I'd see those videos on your website. That's my story. I want to know about this. So,
and I just want to point people to those videos, because those patient videos are very, very powerful. Is it Restore Back Pain?
Yeah. So they'll be on our new website, which is Evolve Back Pain Academy.
Right. But those people should watch those.
Yeah.
So they're very, very powerful.
Hope.
They build hope. Yeah.
Yep.
And there's so many different ones with different...
we deliberately did that. We caught people with different ages, different backgrounds to make people realize, actually, there's some common themes, but everyone's journey is different.
Yeah, and it goes back to what you said right at the start. The message is one of hope.
100%.
Right? You can get better. You can get back to the activities you want to do.
We don't say cure. We're very reluctant to say cure, because if we look at the trial, we saw pain reduced significantly, disability reduced significantly. For some people, they might say, look, it's, pain does not define me anymore. But I get back pain from some time to time, but I know how to handle it. To me, that's the goal. I think this idea of trying to cure something around any chronic health problem, I think can set up a really unhelpful expectation that if I'm not 100, if it's not pain-free, there's something wrong. Where to me, it's like, if pain, we know that you can have pain in your body, but it doesn't bother you. It doesn't distress you. It doesn't define you. It doesn't stop you from, maybe it's a reminder to get more sleep, to go for a walk, to go and do yoga, to eat better, to integrate your life socially. Use it as a signal, not to think, oh my God, why is it not gone? But to say, what can it teach me to do today?
You can use many symptoms
100%.
like that, right? What signal is my body giving me now? What is this symptom saying about the current state of my life?
100%.
Which part of my lifestyle might I be able to change on the basis of this?
Exactly.
It's a different way of looking at the body, of looking at health, but it's a much more helpful way, I think.
But it's evidence-based.
Yeah.
It is. And it's this whole thing you talked about before. It's never a single factor. It never is a single factor. And, what we'd like to do is try and upskill patients to go, you can become your own clinician.
Yeah, I love it. So
and if you hit a roadblock, and here's an exacerbation plan. We know that's really important as well. So people can do really well, and then they hit a roadblock. They get sick, and we've seen this in our research as well. Like the triggers of pain are often not injury. I get run down and got sick. A family member got unwell. Yeah. There's stress in my life. I had a period when I stopped exercising. Everything came, and then my pain erupted again. We give them tools to say, if that happens, this is the thing. These are the things you go through. Try this first. If that doesn't work, contact us.
the belief you have around pain is so huge, isn't it? Because if we think about it through another lens, for people who work out in a gym, right, or lift weights, they will know that sometimes the day after the strength session, you have discomfort in your muscles, right?
Yeah.
DOMS, delayed onset muscle soreness, right?
Which could be really painful.
Can be really painful, especially if you haven't done it for a while. And
or if you're tired and run down and under stress.
But a lot of people will frame that pain as, man, I did a good session yesterday. That's a sign that my muscles they've been taxed and now they're going to grow back stronger, just as I wanted, right?
Yeah.
So that's an uplifting pain.
It is, yeah.
Do you know what I mean? So the way we think about our pain matters.
So important. So meaning is critical. And that's why our beliefs are so important.
Yeah.
Because if we think that pain means I'm damaged, that's got a whole different meaning. So what we know about pain when it's scary is it's severe, it's uncontrollable, and it's unpredictable. That's what's frightening. When pain is, you understand it, and it's controllable and predictable, it's not scary. And so what you're describing, you go to a gym, you do a workout, it's controlled, it's predictable, you get the pain you expected. And so that's the role of a clinician, is to give people an understanding or a meaning of their pain, but also to give them strategies to have more control. We know control is really important, the perception of control, of feeling like, I've got pain, but I can relax, I can breathe, I can do these movements, I can go for a walk, I can get to bed earlier, I can re-engage my body, and it makes me feel better. I'm in control. That's so important.
Let's go back to some of these myths, right? There were 10 of them. I think we covered 3. So we covered the myth that lower back pain is usually a serious medical condition. As you explained, it's not. Myth 2, lower back pain will become persistent and deteriorate in later life. You explained that's a myth. It won't. Most of them will get better and self-resolve. Okay.
And even if you have it for a long time, you still have capacity to get better. We saw people in their 80s get better.
Okay, that is
really important.
Full of hope, right? We then jumped to myth 4. Scans are always needed to detect the cause of lower back pain. You said that is not true.
For the majority, not at all.
Okay. And also the way we message those scans can be important. Problematic. Okay, let's go back to myth 3, which we've sort of covered, but I want to go through these 10. So I think they're very useful for people. Okay, myth number 3, persistent lower back pain is always related to tissue damage.
It's not. Majority is not. Like there's nothing, there's nothing on a scan that it comes back to the scan story again. Like for the majority of back pain, there's not an injury.
So you can move, and even if you're getting pain, if you can tolerate it.
The backs are really strong. Like to actually break a back is really hard, unless you're osteoporotic, in which case that's a different story. That's a pathological process that can weaken your bones, but gradually loading those bones can make them stronger and healthier.
Yeah. Well, it's like loading anything, right? You put force through it, it gets stronger.
Exactly. As long as it's graded in the right way.
Yeah. You said our backs are really strong. Let's expand that out.
They're really strong.
But let's expand that out. We are really strong. We are
100%.
We are strong, resilient human beings who can put up with a lot. And I think sometimes the belief is for pain and other conditions that we're weak. No, we're designed to be able to withstand stuff. We've got strong immune systems that can fight off infections.
Exactly.
If
we care for our health.
We care for our health. If we're able to. I understand also some people have got very challenging lives, and it's harder for them, right? I want to acknowledge that.
It is, 100%.
But if we are able to care for our health, I go back to, my very first book back in 2017 was called The 4-Pillar Plan, and I talked about the 4 pillars of health that I think not only have a huge impact on our health and well-being, but also the 4 pillars that we have a lot of control over: food, movement, sleep, and relaxation.
Well, that's key for back pain.
It's key for back pain, which is why many people who bought that book would send me messages saying, "Oh, this has really helped me with my pain."
100%.
Totally.
And it makes so much sense.
Yeah, because it's like, I didn't give you anything to target your back specifically, but if you improve your general well-being, it ain't just your back that's going to get better. Often your moods,
exactly,
your other symptoms start to get better.
Exactly.
Yeah. Okay. So that was myth 3. Let's now go to, so the fact alongside that then is that persistent back pain is rarely associated with serious tissue damage.
Yeah.
That's a key message, isn't it, for
and
people?
if you do have tissue damage, it heals. The body's ability to heal is amazing. Spinal fractures heal. Disc prolapses reabsorb. The body reabsorbs them. So even if you do have pathology, in the majority of cases, the body will do its thing without any serious intervention.
Okay.
And that's so cool.
Let's go to myth 5, which I think is related to 3. Pain related to exercise and movement is always a warning that harm has been done to the spine and a signal to stop or modify activity.
Yeah. So it's a really important one. Look, we have this.
Not true.
Not true. No. And we have this innate, we talked about this earlier. If you've got a fracture, it's normal to protect your back. If you have pathology, it's normal and appropriate to protect your back, but not for too long. But if you don't have a history of trauma, let's say you have a flare up of back pain, you just, roll out of bed and like you described, overprotecting that will not be helpful.
But the problem is, here's the other thing, which I'm not sure we touched on yet. Once you get into the pattern of overprotecting, it is bloody hard to get rid of it.
Well, that's the trial that we did.
10 years on, you can still be falling into patterns.
Yeah, massively.
You heard when I spoke to Howard.
Yeah.
Literally when I spoke to Howard Schubiner in this studio, a few weeks before that, this was a couple of years ago now, my mum had fallen. My brother had called me to say, hey, mate, I can't get mum. Could you come around and help? And I was in a really good place. So instead of going around in a stress state, thinking, oh my God, if I'm going to do this, I'll help mum, of course, but it will botch my back up. I went around, chilled, smiled, had a joke with mum, and with really uplifting, positive energy, totally relaxed. I got her back up, put her back into bed, made sure she was fine. You know what? That was absolutely fine.
Yeah, 100%.
But that was years after I'd had any serious backache. So I still had to remind myself, you don't have to go and contract your core and keep your back straight, which is quite hard to do with another human being as well.
It is. We use the analogy of the clenched fist. Like, it's normal to clench your fist if you're going to pick up something really heavy, but you don't do it if you're writing. Like, you don't walk around doing this all day. It's not normal. It's not helpful. We see people with back pain doing it all the time. They do it when they roll in bed. They do it when they get off a chair. They do it when they bend over. So if you did this all the time, we asked them, how would your arm feel? It'd be painful. Your joints would get irritated, makes you really stiff. What do we know are the features of back pain? People move stiffer, more guarded, more tense. That's what happens.
And of course, asking people to do those things and brace and stiffen and tighten their core, whatever else they're told, for some people can be helpful.
Well, it's helpful if you're lifting a really heavy load. It's not normal if you're bending over to do up your shoes. It's not normal if you're picking up your kid. If you've got a little baby, it's not normal. That is not normal. It's not normal to roll in bed doing it. That's what we see people with chronic pain do. They brace to roll in bed. They brace to get out of bed. They brace to put on their shoe. They're using something that you and I would do with a very heavy load during normal activities and movement. And they're depriving themselves of movement in the back, which is important for its health.
Yeah. I think there's also an argument that if you do work on your movement mechanics and get them back to optimal, whatever that word optimal means, then your body will naturally kind of know what to do in these situations.
Yeah, I think you touched on something really important earlier. You said a healthy back is one you don't think about. It's one you trust.
Yeah.
And if you trust it, you're not thinking about how you move. You're not thinking about how you lift. You learn that. Look at a child learn to develop. They're not taught to lift. They learn through play and through activity. That's how we learn to move.
They do not go down with this.
No, they don't.
Straight back.
No, they don't. They do a perfect deadlift.
Yeah.
So part of that journey of building trust in the body is to say, you know what? My back is strong. I've got confidence in my body. I don't need to pay it attention anymore. I don't have to prejudge everything I'm doing anymore.
Yeah. And
I can trust it to relax and move. And I need to be strong to do heavy stuff. I have to be strong.
But you also, I think, told in your own personal story that this over-contraction all the time actually becomes problematic because you don't want this always contracted.
It's not healthy.
For certain movements, you need this to be relaxed.
Yeah,
and for people listening, I'm pointing to my abs and my core, right?
Yep.
You don't want it tight all the time.
No.
It needs to relax.
I understand. So if you look at the core, it's great for push-ups, sit-ups, planks. Like that's its job. Twisting. You need a core muscles to hit a tennis ball, to drive power through the body. But it's not normal to bend over. It's not to be clenching those muscles. It's not normal to be clenching them when you roll in bed or bend over a sink or whatever. Wash your face. That's what we see people with pain do.
Yeah. That reminds me how I used to wash my face or shave when I had backache.
Prop off your hand?
Yeah, prop up my back.
Which braces your core?
Bent my knees because I'm very tall. I'm 6'6.5", almost 6'7".
Yep.
So to get into the bathroom mirror, because most mirrors aren't high enough for me, so you'd have to bend a little bit, but you'd keep your back straight. And it must have been comical watching me back then.
Yeah.
Now, listen, I'm not at all criticizing any healthcare professional. Like, I saw some brilliant healthcare professionals.
I was teaching this stuff. I was doing this stuff in my early career. I am not judging clinicians.
You're just trying
That's where I came from.
You're trying to say there's a better way, there's a more helpful way.
And the messaging is so important. Don't frighten your patients unnecessarily. Build hope in the body. Be a movement optimist.
Myth 6. Lower back pain is caused by poor posture.
It's a massive belief.
When sitting, standing, and lifting.
Yep, massive belief. So
not true?
Not true. There's not a single study that supports that.
To make sure you're taking action after watching this video, I've created a free breathing guide that's going to help you reduce stress, calm your mind, and boost your energy. In this guide, I share with you 6 really simple breathing practices that work immediately. Even just 1 minute a day will start to make a big difference. To receive your free guide, all you have to do is click on the link in the description box below. So why do we think poor posture is a cause?
I think it's part of, our senses, what we think looks beautiful. I honestly do. I think it's the core thing as well. We have, as a society, we teach, young people to sit in a certain way, hold their bodies in a certain way, lift in a certain way. It kind of taps into something deeply human, I think, what social desirability looks like. But, we judge people. I mean, I watch my daughter in her, going through the whole ballet process of shoulders back, brace your core. That's fine for ballet, but don't take that into your life, thinking that it's dangerous to relax your back. Or, we often see this as like, if you, text neck or, if you sit slouch, you're going to get back pain. There is no evidence to support that. Similarly, just bending over and lifting with a round back, there's no evidence that's dangerous. But we teach people it's dangerous. So it's another nocibic thought, like a negative thought that makes you think, better sit like this and hold yourself like this and lift like this. It creates this unhelpful vigilance on the body.
So I want to make sure we're not confusing anyone, right? So if someone is listening to this and they have got chronic lower back pain and they have been taught to do those things and they are currently doing those things.
If it's working for them, no worries.
Fine. So you're saying if it's working for you.
But don't think of it as a panacea, because I think there's 2 issues with it. We know that the human spine needs movement for its health, right? So vary your posture. We would say, look.
But hold on a minute. Let me just pause you there.
Yeah.
Agreed. This is something I've also experienced myself. The more I can put my spine in different positions, the better.
Exactly. Vary it.
But you're often told to keep that back straight, keep the core on.
Yeah, not helpful.
You're not moving your spine much there, right? You're keeping it quite locked.
But not only that, you're tensing your body. It's not normal. Like, it's literally not normal. Now,
so you're saying you could do it temporarily for a big lift?
Yeah, of course you can. It's not damaging.
But then don't do it when you're just walking as well.
Exactly. But because that's what we know people with pain do. When we look at people walk with pain, they move stiffer. They don't rotate as much. They move stiffer and slower, and they don't rotate as much. Why? Because they're clenched. So we know it's a signature for pain. We've done studies looking at people when they improve, they start moving quicker. They move more relaxed. They don't hold such rigid postures. They start to relax their postures. Yeah. They're less vigilant about their body. They have trust back in it.
Yeah, that's a big one, isn't it? Because the associated fact alongside that myth is that what you've just said, back pain is not caused by poor posture.
Yeah, but if you have back pain, you want to have the confidence to vary your posture, we see people trapped in these rules, and that's what's so constraining.
Yeah, holding your back up straight for 8 hours in a row.
Yeah.
Really hard.
We see it. We see it with people who can't travel in a car and the seats bolt upright. They've got a lumbar roll in there and they're in agony. And it's like, tip the seat back, relax your core, breathe. Well, use your diaphragm.
Let's go to myth 7, which is about a core.
Yeah.
Okay, myth 7. And again, to reiterate, these are the 10 myths that you and colleagues published in the British Medical Journal.
Sports Medicine Journal. Yeah.
In 2020.
Yeah.
So not that long ago, right?
Yeah.
Myth number 7, lower back pain is caused by weak core muscles, and having a strong core protects against future lower back pain.
Yeah.
Again, you're saying that's false.
There's no evidence for it. So if we take number 1, there's no evidence that a weak core predicts your back pain. Number 2 is if you train your core, it's not a panacea to get rid of your back pain. We know physical activity is great, but in actual fact, the evidence would say do the physical activity that you enjoy the most, that you're likely to keep doing forever. That's the one that's good for you. But, we see lots of people with back pain doing all these core exercises, but they can't do stuff they love in their life. And there's nothing wrong with a strong core. There's something not normal about a tense core all the time. And they're two different things.
That's an interesting point, isn't it?
Two different things.
Two different things.
So we say, look, I do core exercise, part of my exercise routine, but I'm not walking around clenching my core. I go for a walk and I bend over and I do stuff. I'm not doing that.
But also, I think a lot of people don't realize, and I'd love your perspective on this, that when you start to move more efficiently, you're also working your core.
100%. When you breathe efficiently, you do.
Yeah, I went for a run this morning and my running posture is so much improved these days. I shouldn't say posture. My running efficiency, my running form, through all the work I've done with Helen, like it just feels fantastic at the moment. And if you're really tuned into your body, you can feel your core's getting a workout. I'm not doing in inverted commas core exercise, but proper, optimal, efficient human movements, and what walking and running are kind of two core human movements.
Massively important.
Right?
Yeah.
That will also strengthen your core.
Yeah. And look, there was a trial that came out from colleagues last week, I think, in The Lancet, showing that walking, for people who are not active, walking is highly prevents future episodes of back pain.
Yeah, walking is the best thing.
It's gold.
Yeah. And also walking, again, I'm sharing this in case it's useful for people. So because I'm almost 6'7", most chairs are very, very small for me, right? Relative to most adults. And if I'm ever at my children's school, right, in primary school, oh man, the chairs, I said to my wife a few weeks ago, just imagine you've got
is not made for you.
Kids, party chair, sit on that for 3 hours, right? That's kind of what it's like for me when I go and sit on these chairs, right? And I've realized once that I did go to an event at the school and my back was really sore afterwards. Again, maybe appropriate because I'd been in a certain position for a period of time that, my long body was struggling to sit comfortably.
And you probably couldn't relax in it.
But I went back there a couple of weeks ago for a musical and I walked to the school instead of driving. No problem, right? So that fits with what you're saying, right?
Does.
Because I had done something relaxing. I was moving my body and my muscles. They were all warm. Then I could tolerate sitting
100%.
in an inverted commas poor posture or poor seat without any problems.
100%.
So it's all related, isn't it?
Massively related. Yeah.
And
it's so important that people get that.
Okay. All right. Myth number 8.
Can I touch one other thing on the core?
Feel free.
Diaphragm. So if you brace your core, your diaphragm fixes. So it's a pressure cylinder. So you've got your pelvic floor at the base, you got your core muscles on the side and the diaphragms at the top. So if you brace your core, you force yourself to breathe upper chest, which is inefficient. And we know upper chest breathing tends to go, rapid upper chest breathing tends to drive the stress system. That's like your sympathetic nervous system.
You're already stressed in pain.
100%.
Right.
And then your behaviors start driving it more,
You're
ramping it up.
reinforcing the pain by your breathing pattern.
Exactly.
Because you've kept your core tight.
Because your diaphragm cannot now function as a respiratory muscle. It's creating pressure.
Right. Now, the reason I wanted to bring this up is because speaking to this idea that nothing in the body works in isolation, right? So someone has backache. It affects the quality of their life. They then get told after their scan that they have a degenerative spine.
Yep.
Okay. Even as I say that, it's like, well, what message that's given?
Yeah.
And then they get told you have to strengthen your core and keep it tight.
Yeah. Hold it tense when you bend, when you move, when you sit, when you stand.
Okay.
Yep.
And of course, this advice has been given with the best intentions. Yep. Right. So that person then, and I've seen this loads, and I've been this person as you have, right? Yep. You're always keeping that tight.
Yep.
So as you just said, that locks your diaphragm.
It does.
Your breathing starts to go up.
Tenses your neck.
Tenses your neck. So you're becoming tense. You're activating your stress response system.
Yep.
But also, it's important to know what started with your back now is affecting your diaphragm and your breathing, but that also affects your pelvic floor muscles.
100% does, yeah.
Right?
Yeah.
And I think this is also worth bringing in here because so many people, men and women, have pelvic floor muscle problems, particularly women.
Yep.
Stress incontinence is huge with women, right?
Yep.
Especially after they've given birth.
Yep.
And if we just map it all together, go back pain's going up, stress is going up in society. We haven't talked about this yet. People are being told, or people are absorbing the message they should suck their belly in.
Massive.
These are all problematic, and they're all contributing to pelvic floor issues as well.
Yeah, and it's true. And like there's good research to support those interrelationships massively. It's a massive issue. And look, you know, we have such, as a society, we're so judging of the body around body form, about body shape, that we see a lot of people trying to hide themselves, like, you know, young women and men or of any age, trying to pull their bellies in to try and hide themselves. That creates the same thing. If you suck your stomach in, you create intra-abdominal pressure, you can't use your diaphragm effectively, you start loading up your pelvic floor, that whole system starts overworking. Your abdominal wall attaches to your rib cage. Yeah, so, you know, the whole system is part of this.
Yeah, and a key point, right, is what we said before about a back. It may start off in your back, but depending on what you then do and tighten and stop moving,
it starts spreading.
You get a secondary problem, a tertiary problem, and I don't know what a fourth one of a tertiary is, but you know,
it's true.
You get all these knock-on effects, right? So if we look at sucking your belly in through the same lens, and I've done this, right? We all do it. We you know, women have had this for years. And I remember when I was like a skinny, rib showing teenager at like 13 or 14, feeling self-conscious about my body. Men's Health came out and suddenly you're seeing all these ripped guys with six packs and flat abs. And you're thinking, oh God, that's what I need to be like to be a man, right?
Yeah.
So this is so widespread that I would say more than 50%, most people are probably sucking in their bellies at some point. And I think it's one of the most problematic behaviors.
We see it all the time.
Let's really hammer home this point because people are doing it.
It's not normal. It's not healthy. It's not useful for anything. You know, if you think about any body part, you don't constantly contract any other part of your body, do you? But we teach people to do it for their belly. Yeah. You think about it. There's no other muscle. You don't sit there trying to contract your biceps or your quad or your calf. Maybe the pelvic floor. You know, the people who are, you know, anxious about the continence or whatever, but the core, massive. But not only that, we teach them to do it. Now, there's a difference between strengthening the core, which I think we talked about earlier.
Which is important.
And consciously contracting a muscle is not normal. It's not normal. We don't do it for any other body part. It's not normal. And, you know, anyone listening to this can sit there, pull in their tummy and feel what happens to their breath. It has to go up here. And they keep doing that for time and then feel what happens to your back muscles. They tense up. If you feel your back when you contract your core, you start tensing your back. Yeah. Now, if your back's sensitive and your muscles are sensitive and you're contracting them all the time, they're not going to be happy.
No muscle is going to be happy being contracted all the time.
No, it's not.
You have to contract, relax.
And people forget how painful a muscle spasm is. We often say to people, you had a cramp in your leg? How painful is that? How painful? Have you had a cramp in your back? Because it's how painful. Because they're not that big. The back muscles are not that big. And if you're constantly contracting your core and you're co-activating, that means because the core are flexors, they pull you forward. The back extensors pull you backwards. You start clenching your core. You're giving work to your back muscles.
Yeah.
You start creating this abnormal overprotection or tension.
And going back to your model that you've created, I think with colleagues, cognitive functional therapy, that you published that wonderful trial, right, in the Lancet. One thing you said to me when you were explaining it is that we give people tools so that even if their back pain comes back or they have a flare-up or their pain per se comes back, they know what sort of things they can do, including relaxation, right?
So diaphragmatic breathing is probably the most important thing at the beginning.
Yeah, so this is really
interesting. It's kind of like
the
platform around which movement begins.
Well, I've had multiple conversations about the breath on this show over the years.
I've heard them,
James Nestor, Patrick McEwen, Brian McKenzie, and many more, right? About how powerful the breath is. What I love to try and do for people is to help integrate it all together. So this may, on the face of it, seem like a conversation about back pain and chronic pain, but it's so much more than that. It's about if you isolate one aspect of your body and overprotect it, there is a knock-on consequence on other parts.
But if you start doing the opposite, there's a knock-on positive effect on other parts.
So if you do 5 minutes of diaphragmatic breathing each day, where you're really relaxing and breathing fully, you're training the relaxation response.
But then integrate that into movement is the next step.
And funnily enough, I think
which is what yoga does, right?
That's what yoga does very well. And I think also, it's funny, when I went for my run this morning, right, I was feeling a bit fuzzy-headed this morning. And I thought, oh, Peter's coming shortly, right? Let me go for a quick run, see if I can just, blow out the cobwebs of my brain, that sort of thing. And maybe because I've been researching your work yesterday, and I was chatting to Helen about it yesterday as well, I was really thinking about my breathing. So I went for a 30-minute run. And my only focus was breathe in a relaxed fashion. Make sure when you're breathing in that it's diaphragmatic and it's going all the way. It was a really relaxed run. My only point of attention for the entire run was my breathing. And, it felt really relaxed because I was focusing on the breath.
Well, there's good evidence for it too. Breathing's so interesting because it is deeply primal. Like it's the first thing we do. It's the first muscle we use when we're born. But it's so linked to emotion, to fear, to pain, to body position. It's such a fascinating area. And, when we start working with the body, often we start getting people to relax their core and use their diaphragm. You'll see emotion emerge, and you go, where did that come from? And it's bottled emotion. Like you described this with your dad. Like this pressure came off. What was that? But something clearly relaxed on your body at that moment when your dad went into the fire.
But also, Peter, you talk a lot about the problem with fear and back pain. It perpetuates the problem, right?
We know it's a massive problem.
And you have this, this beautiful thing about the things that predict. And you shared some of the research on that, whether you're going to have chronic pain or not. One of them is whether you're scared around it or whether you're empowered and relaxed about it.
100%.
Right? So training yourself to relax through diaphragmatic breathing, of course it's going to be beneficial for anyone with pain, right? Because if you're fearful about your pain, your stress response is on high alert.
So that's it's in fright mode, right? You're fight, flight,
but breathing's
and fright.
going to totally switch that off.
Dials it down.
And dials it right down. So again, as part of your armory to fight back pain,
It's one of the key foundations.
Yeah, I don't even like using the term fight anymore. It implies that you're at war with your body, and you're not.
Yeah.
Your body's giving you a signal.
It's finding homeostasis again.
Yeah, it's just a helpful tool, right? So I think that's fascinating.
And I think the other key thing, which often is missed, so we see a lot of people with back pain do meditation or diaphragmatic breathing, but they do it in a safe place where we'd say, you need to do that when you hurt. You need to do that when you're frightened. You need to integrate that when you're doing the stuff that either hurts you, you avoid, or you fear.
Yeah.
So take your breath into the movement. So we do a lot of that work because what you'll realize that they can lie on their back and do diaphragmatic breathing, but when they sit or bend or twist or lift, they hold their breath.
And what did I say about the last time I picked Mum up from the floor? I intentionally went in. I had a joke with Mum. She was fine. Yeah. She just couldn't get up. Yeah. I said, "Hey, Mum, what are you doing here?" And something like that, right? Yeah. It was a light energy. Yeah. And I'm sure that made a difference because when I go intense, when I used to go intense,
well, you set yourself up for failure, 100%,
because you're setting off that fear response massively in your body. It's truly fascinating.
It is.
Okay, that's myth 7. We've got to get through these myths. Okay, myth 8: repeated spinal loading results in wear and tear and tissue damage. Yeah. You're saying that's false?
Not true. Yeah. Well, I think we touched on that a little bit earlier. That
we did,
that actually loading your back makes you stronger. Loading bones is important for their bone health. Loading discs makes discs stronger.
Loading muscles makes them stronger.
100%.
It's
so
how
depriving your back from load is terrible. Now that's different than this kind of internal compression, which is linked to fear or overprotection. We're talking about external load. So say running, for example, it's fantastic. It's cyclical loading of the back. It's very good for the human spine. You couldn't tell someone who's not a runner to just start running. You'd want to grade them up to it. But, the body has got this extraordinary ability to adapt.
Yeah.
To pretty much anything if that's your goal. And that's the key in my mind to build that hope again, to go, don't set limits on your life.
Myth 9: pain flare-ups are a sign of tissue damage and require rest.
Yeah, huge one.
So this is not true.
No. Well, the history is the key. So if you have a flare-up because you've had a heap of stress in your life, you're tired and run down, the last thing you want to do is to avoid movement, right? It's a sign you need to move, to relax, to move, to re-engage in physical activity, get good sleep, of course. But this idea of overprotecting, of course, is the issue. Now, if you've had a traumatic injury, that's tissue damage, right? That's where you do have a period of graduated rest. But the majority of back pain flare-ups are usually linked to inactivity, high levels of stress, poor sleep, rundown and fatigue.
And ironically, I say ironically, but a lot of people don't think about this when they're stressed, but one of the best stress relievers is movement.
Massively. And breathing and exercise,
and
physical activity.
I'm not even talking about heavy, intense workouts. Walking is one of the best stress relievers.
Fantastic.
It's gentle on your body.
Yep. And even if it hurts, you're not harming yourself.
You're not harming yourself.
That's the key thing.
Really, really important point. Okay. Okay, the final myth on your 10-point list of myths, right? And this is a big topic, right?
I know it is,
Okay. Treatments such as strong medications, injections, and surgery are effective and necessary to treat lower back pain. You're saying that's a myth.
Yeah. So what's happened is, what's really happened in the last 20 years is this kind of escalation of what we would call low-value care. Care that's expensive, it comes with risk, and it doesn't do much good, or it's got limited benefit. So if you think of the whole opioid story for chronic pain, we know it doesn't do we know it's not effective. Opioids are not effective for chronic pain. They come with lots of risks. They have lots of downsides. So they just haven't been a helpful drug.
I agree they've not been helpful. They've been downright harmful.
Yeah.
Right? It's not unhelpful. We as a profession, knowingly stroke unknowingly have made so many people addicts.
Yeah. Horrible.
It is.
I've seen it. It's horrible.
I've seen it.
Yeah.
It's not been neutral at all.
No, it's not.
Right? And more importantly, you're saying that for chronic pain, it's not helpful.
We know it's not helpful. I mean, there was a landmark study last year published in The Lancet that looked at opioids for acute back pain versus placebo, showing that the placebo was more effective right out to 12 months. So we just don't have good evidence for it, but the risks are significant. So, but what I think what happens is in primary care, because we don't effectively manage back pain well, we start escalating, and the scan is a driver of that. Because if you have someone who's just, you got the disc degeneration story and you've had, various treatments not working and the patient's getting more distressed, the GP's going, well, we better send you to the surgeon. The surgeon goes, well, you've got a degenerate disc there. You got this, your surgeon gave you a wonderful advice, but that's not always the case. Yeah. Then they're like, well, the patient's desperate. We can fuse your disc. And we know the evidence for fusion and disc replacement shows that, there are significant risks that come with that surgery. Yeah. And the outcomes are no better than non-surgical treatment. So why are we doing it? And not only that, we know that the things that have been operated on are not predictors of that person's pain and disability. Yeah. So what are we doing?
One of the most important questions I think any patient can ask their doctor is this: what happens if I do nothing?
100%.
Right? Yeah. And we need to normalize that more, right? Yeah. There's an idea that I've got a problem, I'm now going to the healthcare professional to get fixed.
Yeah.
Okay?
Yeah.
And the healthcare professionals, with all their training, are doing the best that they can in the system in which they're having to work.
Yeah.
And often that means that there's a kind of unwritten idea out there that you have to do something to validate the fact that this was a consultation, right?
And which is about us, right? As healthcare practitioners.
Yeah.
Yeah.
And I've been here before, so I totally get it. You feel like if you've given them a prescription, you've given them something, you've done something, right? So you feel satisfied that you've contributed here.
Yep.
And your hope is, and I think patients do feel, some patients also will go in with the expectation that going to a doctor means I must come out with a prescription.
But we've created that.
Yeah. So this is not just healthcare professionals. It's also our public perception is that it's only worth it. I took half a day off work. I've waited 2 weeks for this appointment. If I don't come out with a prescription or a referral or a scan, it was a waste of time. And so the system also is playing into this.
It is.
Where people are wanting these quick fixes, but they're not neutral.
We're not honest. Look, physios are caught in the same cycle. That there's this perception is if I go and see a physio and I'm not put on the bed and given a rub down or mobilized or whatever, I haven't had treatment. Like good care is giving people a clear understanding of what's going on. Good care is about empowering them to make change in their life, to get back to the stuff they value. That's good care. Yeah, but we don't value it.
This is one of the reasons why I do this podcast, honestly, right? Because let's take it away from pain for a minute. Any GP or doctor knows this scenario, right? Someone's coming to see them with a cough.
Yeah.
Right?
Yeah.
It's affecting their life. It's bothering them. That it's affecting their sleep. They can't work as well as they want to, et cetera, right? So they go in.
Yeah.
Doctor examines them, looks for the red flags, looks for the signs and symptoms that might indicate a bacterial infection, which may need antibiotics.
Yeah.
More often than not, they're not there.
Yeah.
Right? There's no fever. There's nothing you can listen. When you're listening with a stethoscope, you can't find any sort of localized area of infection, right? And you just think, this is a viral infection. It's going to take anywhere from 1 week to 4 weeks or whatever to get better.
Yeah.
Right? So you try your best to reassure the patient, go, look, I get that you're worried. And of course, different doctors will do this with different approaches, and some are better than others. But it's always, my approach is always to try and explain and say, look, I get that you're worried. I get that you think this is serious, but honestly, I don't think it is. This will get better.
Yep.
It usually takes 1 to 3 weeks, but sometimes it takes a bit longer. Sometimes the cough can hang around.
Yep.
But here's what happens. And I do think society and there's a lot of pressure on people at work. They don't want to take time off, right? 2 parents are working, they're struggling. People have got difficult lives. So it's really easy. 2 weeks later, that patient's like, yeah, I listened to the doc, but I just need some antibiotics now. I just need to get on with my life, right? No one's at fault here. But the system, the medical system, and the state of our culture now is such that people have no time and space to heal. So often that patient will end up back in front of the doctor, and the doctor, even if they don't think it's appropriate, they will feel under pressure to give that prescription of the antibiotics. And then what happens is that a patient will often take it, and in that week they got better, but almost certainly it would have happened anyway.
Natural history.
Right? I'm not saying that antibiotics aren't sometimes indicated. What I'm trying to do is highlight that there is a systemic issue here for pain, but also for healthcare in general, that the system doesn't help, but also our understanding, our beliefs also don't help.
100%. That's the story of back pain. If you look at most people who have an acute episode of back pain might go and see someone, but the evidence would say, whether they do or not, the natural history, if they're going to get better, they would have got better anyway. And if they weren't, the things we're doing probably won't prevent it. So that's again why we need to educate people about, hey, for the majority, that's why those facts are so important. And, there are some parts of the NHS have put these into the system, which is super cool, because I think they're really helpful for people.
Can I just ask, we're talking about medical systems, and I guess how you hear this will depend on which country in which you live and what your experience of doctors has been. But one could argue that in private healthcare systems, people are incentivized
massively
to do scans.
There's evidence for it
that are not needed, and to do procedures like injections.
There is overwhelming evidence
of what?
Overtreatment, over-investigation, and over-treatment
everywhere, or in private healthcare systems.
In private healthcare systems,
because people are making money.
Massively. So, if you look at America, I know, the American system, and Australia is not that different. We have a strong private health care system. If you look at the number of surgeries, spinal fusions in the public care system is pretty much flatlined, and it's evidence informed. It might be an unstable fracture or something where a fusion is indicated. If you look at the work comp, so that's our work insurance system, which is it's a private system, or our private health system, the number of those procedures is exponentially increasing. The number of spinal injections is exponentially increasing.
Hold on. So these things are increasing, but is pain going down?
No.
So that's the key, isn't it?
Not at all.
These things are increasing.
No.
If pain was also going down,
it's not happening.
You'd be like, okay, we're spending more money, but we're helping.
That's why it's low value.
That's what, I mean, I love these words, like low value or unhelpful.
Well, high value.
They're very kind words.
If you think of high value care, empowers people, it informs people, it gets them back to stuff that is important for them, but also cascades into other aspects of their life. That's the healthcare that we should be delivering people. But you know what? It takes more time, and that's the other tyranny of our health system, is that we have a health system that says, no, you cannot spend time with people. So if you can't spend time, you can't take history. You have no time to explore those different factors that are happening with that individual. You're forced to make quick decisions around treating symptoms, not dealing with underlying causes. So we have a massive issue in the way that we pay healthcare practitioners for time. In the Restore trial, they saw the practitioner 7 times. That was it. And then
this is the trial you published in the Lancet.
So it was an hour for initial. Subsequent were between 30 and 45 minutes, 7 sessions, right? With a follow-up at 6 months. These people have been through God knows how much treatment before that.
There was a cost saving, wasn't there?
Yeah, there was. And, the big cost saving is the people in the trial got back to work.
Yeah.
So was it
$5,000?
Yeah, per person per year for getting back to work.
Yeah. Some stats which I've learned through your work, which I think really speak to how badly wrong we've got it. In the US, $600 billion per year being spent on back pain.
Crazy.
At the same time, back pain is the largest cause for disability out of all health disorders.
And it's getting worse.
Those two stats, they don't marry up. Something
one is feeding the other.
Yeah. Okay.
It's horrible. And you know the saddest part is what we see is that people then had a fusion and they're not better. What next? What happens next? It's like, well, I've had
the gold standard treatment and I'm still...
They'll fix my back and I'm not fixed.
Yeah, because, right, if emotions were driving your back pain, and they're not in everyone, right, but if they were a significant part of your back pain and you just deal with the biomechanics, but you don't address the emotions, of course it's not going to go.
But not only that, once you've had a fusion, you get all these messages to be careful because you might do the next level. So not only that, we infuse people with more fear to overprotect the back.
Do you think injections can work?
Look, there's limited evidence. For acute radiculopathy, there is some evidence for some short-term relief in terms of reducing radicular pain. For back pain, the evidence is really bad.
But some patients will say, I think I've had an injection and it felt better.
But if you look at the evidence where you compare injection to placebo injection, they don't stack up well. But, we would say to people, look, it's around benefits and harm, right? So, it does come with some risk. Like I can think of patients who have had, a leak, CSF after an epidural injection, and ended up, affecting, hitting the dura, which is the coating around the spinal structures.
Cerebrospinal fluid leaking out.
And end up in hospital for 10 days. I've had others who've had spine infections. They've had a devastating consequence. Now, they're a low risk of getting that. But if you get it, it's a big deal.
Yeah, and why I think understanding risk is so important. We've grown up in a culture where medicine is key. What the doctor says is king, right? Many of us have grown up in a culture where what the doctor says goes.
And shouldn't be questioned.
Right, and shouldn't be questioned.
Yeah.
And therefore, if the doctor is saying this procedure may help you, you take that on with extra weight. And I don't think we in health have enough of a conversation about risks versus benefits.
100%.
Yes, there may be a risk of this operation, but there is also a finite risk of these problems, right? And then, like you say, if we compare it to placebo, is there really a benefit? Now, for some cases, of course there is, right? But again, if you don't have time in the system, no one's going to have these conversations.
Exactly.
And to be fair, good surgeons are having these conversations.
Well, I mean, we have them too.
Yeah.
Yeah.
And I'm sure everyone's trying to do their best.
Exactly.
But
we often see it as a failure in primary care that they end up being there at the first place.
Being where?
Having to see a surgeon, because primary care should manage the majority of people well. So they shouldn't have to go and see a surgeon if we're dealing with back pain well at the get-go. Okay. The other thing, that I think you're tapping into here is that the problem with an injection is you're not empowered. You're having someone stick a needle in your back. It gives you short-term pain relief. There's no long-term benefit for it. So you just become part of another revolving door. Yeah. So, I wouldn't deprive anyone of pain relief. I never would. But this idea of, we know it doesn't get them functioning again. It might reduce their pain, but it doesn't get them functioning. So if you have some pain relieving procedure, marry it with getting your life back. So at least use it as an opportunity to go through a process of getting your life back.
Yeah, that's great advice. If that injection gives you relief for a couple of months, use those 2 months to put in 100%. Place some great practices.
And all the things we talked about then means your likelihood of going back for another injection significantly reduced.
Okay, Peter, you're doing incredible work in this field, honestly, and it's much, much needed. I really appreciate all the trials that you've published. We'll try and put links to them in the show notes for people who want to check out your papers. Where are the websites that people should go and visit, both patients and healthcare professionals, if they want to learn more?
Yeah. So just to highlight that I'm part of a big team of people. So it's not just my work. There's a whole group of people behind that. So I would want to put that out. That's really important for me. I'm very privileged to work with some amazing researchers, clinicians. In terms of the kind of opportunities for learning, the Evolve Pain Care Academy website, which is this social enterprise, will have a hub for patients, a hub for clinicians.
Amazing.
And all of that's free. So we want to create a way of empowering, because we see it as this partnership. It's not enough to empower the clinician if the patient's uninformed. It's not enough to empower the patients if the clinicians are giving them completely contradictory advice. And that's a place that we want to use to bring patients and clinicians together to work in partnership.
Yeah.
So that's a great place. And on that also we have access to any open access material. We've summarized it. There are patient stories. We've got patient advocates who are part of this process as well. So we're using their stories to kind of empower clinicians as well as people with pain.
Love it. Okay, brilliant. The therapy you talk about, you've spoken about during this conversation, cognitive functional therapy, a lot of that will be on the website as well.
Exactly,
And my interpretation of what I read was that there's kind of 3 components to it. There's 1, making sense of the pain, 2, exposure with control, and 3, lifestyle changes. Is that a reasonable summary?
It is, yeah.
Yeah, okay. I love it. It's so aligned with my belief around health.
Yeah, it is.
And giving people agency and empowering them.
Yeah.
To finish off this conversation, okay, there's so many people around the world who are suffering with pain and have done for many years.
Yep.
For someone right now who is in pain, who thinks there is no hope, what would you say to them?
Well, I would say there is. There is overwhelming evidence that there is hope. And that can seem glib or even insincere, but actually that's what our work has shown, is that we're not promising a cure, but if pain is distressing and it's frightening and it's taking you away from things in your life that give you meaning, then there's hope for you. And part of that hope is to have a broader understanding of pain, to understand that our thoughts and our emotions and our behaviors and the way we use our body can drive pain in our body. And similarly, to turn that around is to shift the way we think, to acknowledge those emotions, to build confidence back in the body, to address other lifestyle factors around physical activity, our sleep, relaxation practices. They're all part of the jigsaw puzzle. And for everyone, the pieces of the puzzle are a bit different. And so, empowering people to kind of be self-reflective, to go, hey, what are the key elements of my pain? What are they? And then, we've had people contact me saying, I've looked at your website and I've looked at your videos and I want to thank you that for the first time in 20 years, I've relaxed my body and I'm starting to move again and I'm feeling hopeful again.
Yeah.
For others, they go, I've seen it and it resonates with me. Where can I go to find help? And one of the things that we're doing is putting up clinicians on the website who are trained in this method. And, we know through COVID, you can do this stuff through telehealth.
Yeah.
And it's not a lot of treatment. It's literally, often for some people, it might be 3 or 4 sessions. For some, it may be 8 sessions, but it's over a period of time and it's an empowerment model.
Yeah.
And it's around understanding and listening and validating of building a new understanding of what's happening and building hope for change in the body.
Peter, we started this conversation with hope.
Yep.
We're ending the conversation with hope.
Yeah.
A huge thank you to you and all of your colleagues for what you're doing and publishing research in this area. Thanks for coming to the studio and good luck for the future.
Well, thank you, because it's people like you that help get our message out. And, it's really hard. I think we touched on this. As researchers, our work gets hidden behind paywalls. It's not often even decipherable for most people. It's kind of in medical jargon. And I think what these conversations do is it brings the person back in. The people who are out there suffering, they know what it feels like. They know the impact it has. They know the journey they're walking through. And I think building a sense of community and hope is the key for that. And you're doing that. So thank you.
Thank you. If you enjoyed that conversation, then I think you are really going to enjoy this one.